Yes, I can record it on my side, sure. And I'll just send it to Jennifer.
That'd be great. Thank you.
Thank you.
No, I do not.
All right, can everyone see my screen?
Okay. Yeah, you bet.
Great, and if I can ask everybody to check their mute, just so that we can eliminate some of the background noise. Hi, my name is Pam Segnis, and I'm the Director of the Behavioral Health Division and the Executive Policy Director for Behavioral Health for the Department of Human Services. And I'm happy to be here today to talk through some of the work that's being done around behavioral health, and also get an opportunity to provide updates of what's kind of happening during the transformation and what's new, but also getting feedback and information. Hi, was there a question? No? Okay, I will continue then. So one of the things I was going to do is just run through some of the slides that talk a little bit about the efforts in behavioral health, and then talk a little bit about how we can continue to work towards improving behavioral health services for students and for families. And starting out first, I think what's most important is just making sure that when we're using words, we understand what those words mean across systems. And so for behavioral health, whenever I use that word, I mean it's really I mean it as an umbrella term encompassing everything from mental illness and addiction, but also things like recovery and prevention or overall well-being. In North Dakota, we often also include brain injury as part of the definition of behavioral health, but in general, we want to see behavioral health being something that's focused on in North Dakota. Similarly, one of the key things we've been working on is that behavioral health is health and should be treated on an equal footing as the way that we consider health. So for example, we expect our insurance and Medicaid and payers to include health benefits, and we want to ensure that behavioral health is treated equally. So that, sometimes in North Dakota, we've seen behavioral health services needing to be funded through, temporary grants or charity. Sometimes people perceive behavioral health to be more of a social services instead of considered as health. And so for the last couple of years, we've really been focusing on educating and developing our system around the reality that behavioral health is health. So the roadmap really has been over the last couple of years, and some of this was before my time in my current role. But in 2014, we really started seeing movement in the behavioral health system. And it started with an interim study called the Schulte Report. And that was published in 2014. And the Schulte Report was really a call to action. It was a study that came out and said, hey, North Dakota's behavioral health system is in a state of crisis, and we need to respond. And so it really was the first time that people started having awareness and recognition, at least very publicly, that there were needs in the behavioral health system that weren't being met. And it's really the beginning of some momentum. However, there were limitations to that study in that it didn't create a clear path forward. For example, there wasn't consideration of dollars or spend, or even some data that would help with understanding the scale or the scope of the problem and the way to address it. So in 2016, North Dakota continued looking more into what are the gaps and kind of doing an assessment of resource in order to move forward into what was later published in 2018. And that was commissioned through the Behavioral Health Division. We commissioned a study with the Human Services Research Institute to study North Dakota's behavioral health system based on all of the work already done since 2014, but for the first time including that data and also information about what North Dakota was spending in regard to behavioral health. And ultimately what we learned was when the report was published in April of 2018, that there were significant areas where the state could make improvement to that behavioral health system. And the study was a 250-page plus report that broke down 65 different recommendations into 13 categories. And those categories are fairly broad, but wanted to just share them with you because it really led to the movement that was brought forward in both the governor's executive budget for the department, but also in the legislative strategy. And so these are the 13 key things that were brought forward by the report. And you'll see it's everything from investing in prevention and early intervention to partnering with tribal nations, really focusing on, enhancing and streamlining the system of care we have for children, and then focusing on those community-based services so that we have access that's readily available when services are needed. For more information, we do have the full report and all of the work that's been done since the original publishing of the report on this website. So I wanted to make sure everyone knew that was available. And then the next couple of slides are examples of some of the data that's included in that full report. This is the amount of spend that North Dakota spent in 1 year on substance use disorder treatment services. So this includes Medicaid spend, but also funding for the human service centers or the public behavioral health system. And what you'll see is that in that 1 year, there was $19 million that was expended. And more than 85% of those expenditures were focused on residential and inpatient services, which is the highest level of care. The majority of people with behavioral health needs don't actually need residential or inpatient care. They can actually find recovery and the services that they need, if available, in a community-based way, in supports where they live, with their family, in their school. And so if you look here, only 1% of our spend of that $19 million was spent on youth outpatient services for addiction. So, this really brings up the question, which is there a need for new money, or is there potential also to look at the way that we're currently utilizing the dollars that we already have in order to maybe better meet people's needs? On the next slide, you'll see the same thing, except now with the mental health spend. And so now we're looking at a total of $59 million within a year. And this does not include the state hospital. So that number would be quite a bit higher if it included the cost for the state hospital. But once again, we see that residential, inpatient, and long-term care facilities accounted for the majority of the spend for mental health services. And once again, we want to look at that and say, what if we took even just 5% of $59 million and found a way to reinvest that in community-based services, meeting people where they are? And so this is the data that was presented in the HSRI study that really led forward to a path of, so what do we do now? So in the summer of 2018, the HSRI study was presented to both the Health and Human Services interim committees, at which time both committees endorsed the recommended path forward, and we saw funding provided then to start implementing these programs. So that leads us to one of the things that's probably most important to understand about a behavioral health system that's effective and that works. It's that we need to support the full continuum of care. And just to give some examples of this, right now the majority of our spend in North Dakota and our resources go into that highest level of care or that treatment, that acute treatment world. So there's lots of opportunities that we miss sometimes in behavioral health to provide early interventions. Most of our reimbursement, for example, doesn't kick in until there's a diagnosis. But we know that if we could intervene at the point of first symptom, we would have an opportunity to provide interventions that could potentially change the trajectory for that student. And so, when we look at how we could make changes in North Dakota, investing in early intervention and prevention could really make a difference. And ultimately, the best thing for a comprehensive system is to support all of these different levels. Whenever we can prevent an illness, we should. Whenever we can have an early intervention that could change the trajectory, that would be preferred. We need to serve individuals who have a treatment need. So treatment is still an important component, but it should be the right type of treatment for the person to meet them where they are. And then lastly, having recovery support services. One thing that we frequently see in our system is that even if someone is able to access treatment services, they don't necessarily have services that continue with them in a supportive way as they either reintegrate back into the community if they've been, in a residential facility, or those more ongoing community-based services that can lead to success. So this continuum of care is really kind of the basis of what a comprehensive and effective behavioral health system should look like. So approximately 2.5 years ago, and like I said, I've only been in this position for a couple of years, there was a lot of discussion happening about the needs for children and for students in the education system specific to behavioral health. And just to be really clear, I think, just in the information I presented so far, you can see that the behavioral health system is not meeting current need. And that's not just specific to students, but really to a large portion of the people that we are hoping to serve. And so I had gathered a group of just individuals and representatives from different parts of the education system, from associations to administrators, working with REAs, special education, classroom educators, just different representatives, because part of it was really kind of figuring out, where do we connect? What are the issues? What are we trying to solve? And so we spent some time just kind of in a room trying to figure out the problem and talk about what are potential solutions. And one of the first things that we came to realize is that we have different language. And so often we might have been talking about the same thing, but it wasn't always clear. And so the idea that language really matters across these systems really became pretty clear. I personally experienced that myself also as a parent. I got a call from an emotional disturbance specialist. And even though I'm, the director of behavioral health, I didn't understand exactly what an emotional disturbance specialist is. It's a term that's just not used in behavioral health, and it's not a credential that people in behavioral health are familiar with. So, as we started talking, we had to kind of figure out where we had connections. And one of the key places was the overlap between MTSS and the continuum of care. And for many of you, as I covered the continuum of care, you may have been thinking, well, that sounds familiar to, what we think about when we look at the tiers. And so we actually took markers and started mapping on the board and kind of laid out like, okay, so tier 1 is this. That's prevention and some of the early intervention that we see in, the continuum of care. And here's tier 2 and tier 3. And, for the first time, we started kind of seeing that connection, recognizing that we were saying things that were very similar. One area that we also worked on defining was, lots of times, even today, I still hear a lot of times people use the word behavioral health interchangeably with special education. And I think we all know that there are significant differences, but I think that based on your perspective and the area that you work in, your view of this is different. So, for example, we have many children with behavioral health needs who will not qualify for special education. Sometimes these are students that are suffering abuse or trauma, and school is a safe place, and they actually do fairly well academically, although they still have a need for behavioral health services. We also see that there are many special education children who don't have behavioral health issues. And so there's this important overlap where we are serving children in both systems, and that's necessary, but there's times where we're not fully meeting the need. One of the places this became evident to me in the last couple of years, I was at a legislative hearing, and I had heard for the first time that Medicaid wouldn't reimburse for a behavioral health service unless it was on a child's IEP. And as a behavioral health professional, that was surprising to me because I realized how many students we have that have behavioral health needs for services that are considered medically necessary, but they wouldn't, again, qualify for those special education services. So this is just an area for us to continue to really focus on and make sure that we have policies and reimbursement and things that make sense for both systems. And lastly, that kind of brought us to the question of, even when we look at credentialing, often when I meet with people, they'll say things like, well, that's just a naughty kid that does, naughty behaviors, or this kid is doing it on purpose. And one of the things that we struggle with a lot in behavioral health is that it's really difficult to, the symptoms all look the same on the outside. We can have children who are, experiencing significant abuse or neglect, or dealing with a significant behavioral health issue. And externally, their behaviors look the same as perhaps a child who's just being naughty. So one of the things that we continue to look at is, the why. Why is the child behaving the way that they do? And I think we need to continue to talk about who decides the why. Not every school system, and though many are, not all school systems have, people who are trained and skilled at recognizing the difference and knowing what those interventions should be. And this really brings up one of the last categories that we identified a need to further develop, and that is that our credentialing processes in our professionals are very different and separate also. Behavioral health professionals are identified in North Dakota Century Code. In fact, they're laid out in tiers that identify their scope of work. For example, those who can commit somebody to the state hospital or who can provide independent clinical practice. Those things are all laid out in Century Code and administrative rules. And then there's, a similar process through special education that is different than what we're used to in the behavioral health professionals. And I think one of the only titles that crosses into both is school psychologist. And so it's just important that we continue to look at the opportunities we have to work to have better understanding and perhaps even build some synergies or some opportunities for professional growth for our workforce. And lastly, that brings me to legislative updates. So as I mentioned, we came together several years ago and said we really need to get together and have one clear focus if we're going to see the change and be able to drive the focus of developing an effective behavioral health system. And so these are the three key things that we focused on. The first is that we need to support that full continuum of care. One of the things that's difficult with that is we're often struggling and fighting for the same resources. And so it can feel competitive even just within the behavioral health field. Treatment feels like they might get cut if funding gets moved into prevention, or prevention is trying to compete with recovery. And so one of the things that we agreed to is that we all need to come in recognizing that we can't cut one part of the continuum to expand the other. I mean, ultimately, we would hope our goal is that if we prevent in the long run, we will see a reduction in cost and in services needed for people in treatment, but that doesn't happen overnight. Second, we need to increase our community-based services. And this has to do with our over-dependency on residential facilities and inpatient facilities. But if there are no other options, that's what we have. And I think in many areas of North Dakota, I grew up in a very rural part of the state. The only thing that we know of when we think about the services needed, it is where someone goes or what type of residential program will take them. And so it only makes sense that if we don't have robust community-based services that are working with families and children and meeting them where they are, that we will continue that over-dependency, sometimes in actually removing children from their families or removing parents from their communities. Lastly, another one of our key focuses was preventing criminal justice involvement for individuals with behavioral health conditions. Because of the significant gaps and the lack of ability to meet the need in behavioral health, the criminal justice system became, in some way, a de facto behavioral health system. There are services in North Dakota that you can't access, behavioral health services, unless you've gone to prison first. This also happens a lot in our juvenile system. We have children who are unable to access services unless the parents have been found guilty of abuse or neglect, or if the child has actually come into contact with the juvenile court system. And so it's a bit backwards if you think about an effective continuum of care. We would want to ensure that children are not becoming engaged in those systems if we can offer services before that. So those are the three things that led into the last legislative session. Many of you have probably heard that there was a great amount of investment in behavioral health during this last session. We historically have gone into a legislative session hoping to get, one of the 5 things that we ask for that are vitally needed, and sometimes we're just grateful to come out without cuts. But this year, this last session, I can say that legislators, the governor, and overall, all of our partners have really worked together, including DPI and the Department of Health and all the effort that has been brought together to focus on addressing the behavioral health issues. So I'm proud to say that this year, or this last session, there were significant investments. However, I know that people have been expressing frustration that they haven't seen those things come to fruition yet. So I wanted to provide an update today on where some of those projects are, but then also reassure everyone that the majority of the items that passed last session to be implemented do not begin until the second year of the biennium, which is after July 1st of this year. Legislatively, they were either written that way in our budget bill or they were funded for only 1 year of the program. So I would ask for patience and understanding that we are working on things and that we hope to be able to provide information shortly about the funding that will be available in the second year. So this slide that I have up right now is Senate Bill 2012, which is the Department of Human Services budget bill. And along the left, you'll see section numbers. If you want to actually go read the bill itself in more detail, that information will guide you to where the information is located. The highlighted items are the ones that directly impact children or families, and so I'll just highlight a few of them. The Substance Use Disorder Voucher is a state-funded program that provides funding for individuals who need addiction services. The age eligibility was 18, and we did get the authority to reduce that down to age 14, which means we can now offer the voucher services to individuals ages 14 and older. The voucher, and we've actually already done the administrative rules, been through the hearing, and those rules were promulgated on April 1st, so they took effect. The benefit of the voucher is that we're able to offer services that are not covered by traditional insurance or Medicaid. For example, we can pay for transportation to and from treatment. We can reimburse for recovery coaches. So there's an opportunity to provide additional services and support for families, especially for those children between the ages of 14 and 17. We also have the Parents Lead program. Hopefully you've all seen parentslead.org. We right now have a lot of information available specific to COVID, everything from age-specific content for talking to your kids about COVID, if you have a family member that tests positive, even just dealing with grief and loss related to graduation and kind of missing milestones in individuals' lives right now with everything that's going on. We have resources available on, addressing and dealing with when you have adult children moving home during this pandemic also. So those are things that are all available, and just wanted to make sure that I mentioned that. We're grateful that the legislature saw it as important to continue to fund that effort also. And then just moving down a couple of things, the suicide prevention program used to be in the Department of Health. That has now transferred into the Department of Human Services, and we think that will allow us to be able to do more comprehensive suicide prevention work, which is so vitally needed in North Dakota. Suicide prevention before was in a different agency and separate from the behavioral health services and system. So we're grateful for that move also. And the last item in section 1 is statewide behavioral health crisis services. So up until this last biennium, North Dakota legislature had funded crisis services only in 2 regions of the state, and only one of them had actually come to fruition, and that was in the Fargo region. So in most of the other areas of the state, behavioral health crises are mitigated through law enforcement or other types of services. This last session, the legislature did approve behavioral health crisis services to be established in all regions of the state. And so those are being implemented through this year. Every region looks a little bit different, so I can't answer to the timing of each region. Some were more prepared, and then some other regions have some workforce issues that took more time. So I would just recommend kind of checking in with your regional human service center and seeing where those behavioral health crisis services are. I do think that that's a big step forward, but there'll still be an opportunity, I think, to focus more on children. Historically, behavioral health crisis is sometimes still too late as an intervention point, so we want to see how we can still continue to implement services sooner. Item number 5 is a community-based behavioral health program. The Behavioral Health Division had started the Free to Recovery program, which provides community-based services for individuals that are on probation. We got approval to expand that program to be able to serve families. And so although the program is based on parents, we are able to bring services to children and families when we have parents that are experiencing addiction or mental illness. And that program is actually based on outcome-based payment. So, we don't specify how the programs help the family, just that they do, and that we see progress in the goals that are expected. Things like stability, housing, recovery. Items 21 and 22 are both school specific. Item 21 is school behavioral health grants, and that was previously brought into session as Senate Bill 2300 by Senator Davison. And the grant is based on schools being able to apply for behavioral health funding through the Department of Human Services Behavioral Health Division up to the amount at which they bill Medicaid. So if a school were to bill Medicaid for, say, $50,000, they would be able to request a grant from the Department of Human Services Behavioral Health Division for up to $50,000 to enhance behavioral health services. The legislators were clear, though, in the language that it can't duplicate things that already have funding. And so, for example, if it's a billable clinical service, the expectation is that this grant funding would not be used for the part that's billable, but instead for the services that are not billable that support that child and family. Item number 22 is the school behavioral health program. This was a pilot that began during the last session in 2017. We had sent out an invitation to apply for schools to participate in a pilot program, really focusing on the integration of MTSS and addressing Tier 3 students with behavioral health services. Simile Middle School in Bismarck was awarded that program, and they have built out the program and seen significant progress in reducing their delinquency and out-of-school referrals. So one of the benefits this year was that we were given authority and funding to expand that program to a tribal school and a rural school in order to utilize that same model. And it's basically like a proof of concept showing that you don't have to be in an urban school in order to implement those same types of strategies. The Simile project is a partnership between the Behavioral Health Division, Simile, and also Sanford Health. Item number 38 expands targeted case management. This is expanding to private providers. Up until now, private providers could not bill for targeted case management, which meant that people who needed that service, whether they were a child or an adult, they would have to seek that service through the public behavioral health system, like the human service centers, or through a tribe. But private providers were not able to bill for that service. So the goal would be expanding access points to service providers. And then lastly, item 41 is kind of the big item that passed, and this is the 1915I. The 1915I Medicaid State Plan Amendment was a change to the Medicaid plan that brings forward services that have never existed before for individuals with addiction, mental illness, or brain injury. So in North Dakota, if you have a child with a developmental disability, you can qualify for services such as respite care or different in-home services that right now are not available unless your child has a developmental disability and not available for individuals with a serious emotional disturbance or a mental illness. So the 1915I, we spent the last year working on. We did public meetings around the state, getting feedback before we started drafting anything. And after the draft was put together, we also put it out for public comment again, received more than 100 written comments and suggestions. And just in the last 2 weeks, we've now submitted the Medicaid State Plan Amendment to federal CMS for review with a goal of having implementation of July of this year, which was the legislative expectation. The 1915I provides services for both youth and adults, which is a benefit because, it's difficult when you can only serve children or parents without being able to serve everyone. And so that's a real benefit. Some of the other services included in the Medicaid state plan include services like non-medical transportation, supported education. So when I talked earlier about children that might have a behavioral health need but not qualify for services in special education, this provides a funding source for those types of services. And respite care can be really important for parents in being able to maintain, a healthy home environment, keep their job, be able to meet the needs that they need to as a family. And so I think, there's going to be some pretty significant changes. One other area that's important in there also is supported housing. So the plan includes pre-tenancy services, so we can help people find permanent housing, but then also support services to keep people housed, which sometimes is even more difficult if individuals are struggling with mental health or addiction. So those are all new services that are in the 1915I, and at this point, once we get federal approval, will be available to providers in the state. So it's just a couple of other quick bills I wanted to mention. House Bill 1103 was specific to opioid treatment medication units. In North Dakota, we only have 3 methadone clinics or medication units for individuals who have opioid use disorder. And this is the type of program where someone goes in daily and gets their medication in order to help with maintaining withdrawal and seeking their recovery. Most of the individuals that are in these programs are not using substances outside of this medication, and doing the things we all do, getting up, going to work, taking care of their kids and their families. But because we only have 3 in the state, Minot, Bismarck, and Fargo, we have families that get up before school, drive 100 miles one way just to get their daily medication at 6:30 in the morning to turn around and drive back home and drop their kids off at school and go to work. So this allows medication units to be set up closer to where people live, and we're hopeful that the current opioid treatment programs will look at expanding their services to meet those families where they are. I mentioned earlier the substance use disorder voucher. There was one exclusion with that, which is that it required the programs that we pay to be private, which means that tribes and local public health units were excluded. So we did request a language change in that so that we would be able to provide reimbursement to tribes and local public health units. And so that also passed. Next, you're all probably familiar with Senate Bill 2149. This is the Behavioral Health Resource Coordinator bill that each school within a district shall designate an individual as a behavioral health resource coordinator. But there was a companion bill, 2313, which also directed the Behavioral Health Division to provide resources to those behavioral health resource coordinators. This was something that was not funded, so it is an expectation of our Behavioral Health Division, and we've been working on getting funding in order to bring that to fruition. So our goal is that by next year we'll be able to have, everything from webinars to live connections within your region of who if you want to triage or discuss a situation about a child and talk about what local resources are available or what your needs are, that there will be a local connection for you in each region. And so that was Senate Bill 2313, which also had a couple of other items. They developed a children's cabinet, which is a cabinet that works across all of the state's branches of government and the tribes. And Superintendent Baszler sits on that along with the Lieutenant Governor, a Supreme Court Justice, and also legislators. The group is chaired by Representative Pollard. And lastly, the bill also created a commission on juvenile justice to address the current juvenile justice laws, which have not been really updated since the 1970s. And so that's something that they're looking at. And that has an important impact for what I discussed earlier about services being available before a child is in the criminal justice system or the child welfare system. So that is kind of the updates and all of the information. And I'm not sure if Kirsten's been able to join, but I will take any questions or feedback or any discussion that anyone has. Thank you.
Thanks, Pam. And yes, I have joined. Thank you. I joined about 1:02 and you guys had rightfully kicked it off. Thank you. Thanks for everybody for joining us today. Thank you, Pam, for providing that overview. Generally, I begin the kickoff session by just thanking everybody for joining, giving a little bit of background information about why we're all gathered here on May 14th. When actually the plans for what was supposed to be a face-to-face in-person listening tour with Pam and I traveling around the state, we began the planning for that in January of this year, January of 2020, because as Pam, has alluded to, there was lots of conversation and lots of work done in the 2019 session. A lot of work began in 2017 between DHS and DPI, as well as the ESSA committee and the steering committee, the K-12 Strategic Visions Steering Committee, about how we might be able to coordinate and get ready for the 2019 session. And so Pam had presented at the North Dakota Governor's Innovation Education Conference this last summer, 2019, then began the fall tour of the multiple conferences where I know that she presented at school boards, at the North Dakota Fall Educators Conference, at the administrators conferences, school board conferences, and her own behavioral health conference in the fall. So as we finished those presentations, we felt that it was important then as we moved to the next stage. Pam talked about the bridging dollars that were put into the bill, into the omnibus bill that she went through. And as those rules were being prepared for a release of those dollars of July 1st, 2020, we felt it was important to visit with all of you within your regions to hear your questions and to have the Department of Human Services Behavioral Health Division understand the situations that were occurring within our school districts and the opportunity to have that perspective as the rules and the guidelines for the application process are being written and being developed. Well, as we all know, the end of February, first part of March, coronavirus took hold of all of our lives, and we needed to put first order business of COVID-19 and distance learning. So here we are at May 15th, and as we had to do in our educational settings, so did DHS, particularly Behavioral Health Division, needed to make the pandemic and COVID-19 their first order business as well. So they did need to set aside, and Pam's office, Pam's division, had taken on some enormous responsibility as we're not only we helping our own students and their families with the challenges and the issues of behavioral health issues and trauma that has been brought on by the COVID-19, so has the Department of Human Services, a much broader audience, those including nursing homes, those that are homeless, and all of the other multiple vulnerable populations within the state of North Dakota. But we do appreciate the opportunity today because, again, as you know, as we all know, as Behavioral Health Division, Pam and her team knows, we will be in school again this fall, and those same students that you were struggling to serve with the right services and needs that were in your buildings last school year during the 1920 school year will be coming to you with possibly some augmented and more significant and exacerbated situations. And so it's important that we have these conversations, and it's important, I guess, for us to hear from you as we continue to move forward as not only implementing the bill for the bridging dollars, but also as we plan for the 2021 session. As we all are very aware, and in the midst of all of this COVID, so is the energy crisis that we've been experiencing that impacts the revenue for our legislature. And it will be very important for the educational community to be viewed by our legislators as working with our behavioral health providers within the state, our behavioral health state agencies, so we aren't duplicating services, but working as one as government. So with that, I guess I will just end again by saying thank you, and then kick it off to Jennifer or anyone else within the REA for any other comments and or questions.
Hey, Kirsten.
Hi, Jen.
Thanks so much for being here, you and Pam. I guess I don't have anything to add personally, but if our schools that are out here, I know that our board president, Connie, is online. Aaron Lucina, I see, might have something to add, but see a few counselors in the mix too.
This is Pam. I have one thing just to add while people are maybe thinking of their questions, but we are working on a timeline right now that we will be providing just to kind of assist with all of these moving parts so that you can better prepare and plan also for, you know, what you need to be thinking about that's going to be coming up in the next couple of months. We had planned to release this honestly about 8 weeks ago, but with everything that's happened, we've had to prioritize, you know, funding and all the services for behavioral health that have transitioned. No difference than how you've transitioned to distance learning. We've transitioned to telehealth. So it's been really important for us to focus on that, but we are working right now on that timeline. And I think that will be helpful just to be able to see, you know, what's coming when, and we'll be providing guidance for the behavioral health grants and making sure that you're aware of when the pilots will be released so that any schools, tribal or rural, that want to apply, that they know when that will happen. And I also just want to reassure everyone that, you know, we realize that it's important that we do things as simply as possible. So you won't need a grant writer. So this isn't like a federal grant for any of you that write federal grants, which we do often. We've done 5 in the last 4 weeks, just with all the COVID work. You won't need that type of skill set in order to complete the applications for this. We really want to make them user-friendly, where you can share what your goals are and what you're working towards. But hopefully that'll be something that will be easy to understand.
Thanks, Pam. So one of the things that I most appreciate about Pam's presentation, both this one and in the past, is the fact that she recognizes that what the Schulte report uncovered, and that there was a lot, she calls it a broken system. And I would just be probably kinder than that. It's similar to our PICUS report. The Schulte report is very similar to the Education's PICUS report, where there was a comprehensive analysis and then the recommendations were made. And so just like our PICUS report revealed how we could be better and we needed to be better with certain steps, that's what the Schulte report did. And kudos to DHS for acknowledging that they were broken. Pam and I are very frank with each other, and we've talked that in the absence of supports from what was and remains, and Pam's honest about that, a broken DHS system, school districts needed to make decisions, and they hired people to meet the needs of their students, because in the absence of doing nothing, we had to do something. But now as we move in, and our legislators, the same legislators that are hearing our budget in appropriations, are hearing Pam's budget in appropriations. And when they see and hear and recognize that we're asking for behavioral health supports or more money for mental health or behavioral health, they're wanting to know why we as two state entities of publicly funded services aren't working together more closely, because they'll see the same type of requests in a DHS budget. And so rather than have them tell us specifically and prescriptively what we are supposed to be doing, I think it's going to be better for us to say and figure out, hey, we don't have to hire all of these people. Where can we break down some barriers? But we also have to have the understandings and the assurance that when we determine that we're going to do that, then will there be the supports there that we need for our children? And if so, how can we learn more about what we need to do, and how do you need to learn more about what you need to do, vice versa? So with that, maybe that opens up some different types of conversations or questions, or even sharing of situations that you might want to provide today from your region. And I'll shut up.
Hi, Kristen. This is Connie Huvendick.
Hey, Connie.
Hi, I just have a question. With the COVID and everything that's going on, there's kind of been a loosening of the rules on teletherapy, and we've been able to access that a little easier. Do you see those rules tightening back up in the fall, or can we plan to continue to use some of that?
So I'll kick that to Pam.
Yeah, absolutely. So this is one of the primary conversations we're having. You know, there's several different components to this. What Medicaid does is different than what Blue Cross Blue Shield is going to do, which is different than what the boards do. So the question has several different facets. But I will say, in regard to where we are as a state, we are trying to figure out how we can transition some of these things that are temporary executive order or payment strategies, how we transition those into more permanent. You know, we recognize that studies have been done on telehealth that, you know, they certainly can be considered to be equally as effective, and for some people even more effective than in-person therapies. So we're supporters of telehealth, but I can't speak for what will be allowed in Medicaid or the private payers at this point, but we certainly are supportive and have made recommendations for those executive orders to allow those types of services. So that's where we are. Yep.
Yeah, thank you. Because, you know, I just think with the time off and all the things that kids have gone through, the needs are going to be higher in the fall when we come back, and we're going to need to have services for them.
Yeah, absolutely. You know, that I do think that sometimes people don't think about that tricky part in between. There's kind of like three phases. There's like the acute emergency phase, right? Like that's the phase where we do the emergency executive orders and they last for a period of time. But then we're going to have this phase where those emergency orders end before legislative action can happen. And the legislative action is really the long-term solution. So we're concerned about bridging in between. How do we ensure we can still keep services to people when technically the emergency orders end, but yet we haven't been able to be in front of the legislature to make some of those changes? And that's a part that I'm honestly concerned about.
Hi, everyone. What I'm hearing from schools consistently is the need for in-house expertise, you know, especially when we're looking at those tier 2, tier 3 needs, you know, having somebody employed within the district just because the needs have become more severe over time and more students are demonstrating those needs. And so the need is beyond external consultation. They really do need somebody in-house for that. So it's where that funding comes from. But then also the coordination of internal support and external support, how to bring those services better together. You know, really what are those best models out there, best examples of practice in the state or elsewhere that we can follow. And we need to look at both small school and large school models. And we need to look at, you know, some very rural models for that too, where we don't have very direct external services. And it might not be that telehealth is the perfect answer for that either. But, you know, when we're looking at the geographic consideration, the level of need, the amount of in-house support or lack of, you know, the direct community agencies right there in that community versus a lack of, you know, there's a lot of things we need to consider. And that coordination of all of that to create the best possible scenario to serve the students, that's where I see schools struggling the most and where I hear a lot of questions.
Can I probe a little further, Erin?
Yeah.
Okay. So when I hear you say we need to have, and I think I hear the same thing. We need to have people in-house. They become so severe, they've been so frequent, and they're much more intense. And so we need to have somebody in-house.
As a first level of support, yep.
As
like
a
an
first
immediate
level.
response kind of support, yep.
Okay, and I get that. So
Yep.
am I assuming, am I safe to assume that they want it to be their employee? Because I think that's where the rub is coming in with our legislators, is because we're saying we need more money to have that employee, where some of those first level responders could also be an initial billable opportunity. So until I started working with Pam, and do you remember the day where speech pathologists were like, we couldn't hire them? I didn't know that speech pathology, even services provided to a student during the day because it's part of their IEP, did not need to be an employee of a school. Yet we had school districts competing to hire licensed speech pathologists with the same clinics and the same hospitals, but we really didn't need to actually take education dollars to pay a salary of a speech pathologist, where we could have provided, you know, contracted with a private provider, a private speech pathologist provider, and actually the school district wouldn't have needed to pay for it. Their Blue Cross Blue Shield could have, or their Medicaid could have. So when we talk about even those first responders, do we have to have it be, this is your 9-month contract, you're an employee of, I'm going to use my hometown, Flasher Public School, or the, you know, which is the Morton Sioux Special Education Unit?
Right,
Or
it wouldn't necessarily have to be like a full-time school-based employee. Some, especially our small schools, might not have the level of need to that point where it could be an external contract. The benefit of it, though, where there is a significant need, is that that person can also help address the tier 1 system, which then decreases the tier 2 and tier 3 needs.
And I think that's where Pam is at too. It's like being there earlier. But I do think there's a bit of misunderstanding that right now, because of the way, Pam, I'm probably slaughtering and making too simple what your presentation is, so please step in. But that we can do that. We just have to have some changes that she's making now with 1915I and some other things where your child doesn't need to be sick enough. So instead of, you know, sending, when she talks about health and medical health versus mental health, it's like we would never think about going to a provider, a nurse practitioner, and with our child having a temperature of 100 degrees, and that provider saying, you know what, I'm so sorry, I can't serve you. Your child's temperature has to be 103 before we have any services for you. Mm-hmm. But I think where we're at is, I do think that we are conditioned to think we only can go to those professionals when they're sick enough. But
we need
correct me if I'm wrong, some of those services, some of those changes will allow for some earlier intervention. Am I right, Pam?
Yeah, and I could just kind of say, I think that what we're trying to do right now is make sure we have the infrastructure in place so that whatever needs to be set up locally, it can be. Recognizing exactly what you just said, like some schools are going to be small and not have the volume to do the same thing that a larger school would. So really what's happened right now is almost like financing reform. Private businesses can't exist if there's no billing. You know, you just can't expect people to do a service for nothing. So a couple of the things that we're doing is remedying that Number one, there has to be reimbursement for services that help kids and families. Number two, we need to make sure that there's flexibility so that you can meet local need. So if you already have a professional who is a master's level behavioral health person who's working in your school and really addressing those needs, everything they do is billable. I mean, that's the point of having a master's level clinician. So the question would be, could you be billing for their services so that you could be augmenting all of those services that are not billable and bringing more services to children and families? I mean, that's the Medicaid funding. Just for example, from a legislative perspective, Medicaid is a 50-50 match with federal funds. So when you ask for general fund 100% money from the state for something that's a billable Medicaid service, they look at that as a 50% loss, because they could have taken that general fund to do twice as much. So really what we're trying to do is just create the infrastructure of flexibility. So a large school that already has that infrastructure, they can bill and double their services. A school that maybe is not going to have that capacity but has an amazing private partner in the community, they could bring that private partner in. Private agencies already do billing. They know how to do that. The school doesn't have to pick up that skill set. So I think the key here is that every school is going to come in at a different place and have to kind of walk through the plan to say what works best for us. And just one thing I want to add that I forgot to mention is that the funding that was available for the behavioral health grants that start on July 1st, we actually got an additional $200,000 added to that to help schools that aren't already billing Medicaid learn and build the infrastructure to do that. Because we realized when Senate Bill 2300 was brought in, it was going to exclude small schools or schools that maybe won't have that volume. And we've heard that, right? There's schools that are like, well, that's only $10,000 for us. We're not going to bother. It's like, well, that $10,000 would have been $5,000 that you would have had another 10 to do something with. So I think just to say, like, what we're trying to do is change the infrastructure and the ability to be flexible, but then for you guys to really kind of work within your community. Do you have a partner that's already doing the service? Are they the best fit? But I completely agree about the connection. If you are 100% dependent on an external partner, and that external partner doesn't come to meet you where you are, which right now they won't because they can't get paid for those services. So without the financing reform, those providers are never going to come in your doors and meet you exactly where you are unless you pay them. And that's where they're making money right now, because schools can just give them a direct contract. Now they don't have to bill, and it saves them time. So it's complicated. So it's like we all need to be doing our best job to make our dollars go the furthest for the benefit of children and families. But it is complicated, and everyone will have different situations that we need to be able to stay flexible with. So that's really my key part here, is just to really communicate that what's happening will not be directing how you do your work, but more that we want to be able to provide information about all of the possibilities so you can make the best choices for your students and families.
And that's where I think maybe I am hoping that these regional conversations, you guys know your schools best, but as money will become more and more sparse, if I believe there is a role for schools to come together, and possibly led by REAs, depending on whatever your board decides, but possibly led by REAs, to help schools understand that, goodness, maybe we shouldn't just have a contract with them. Maybe we should become better at some group billing and billing practices, and then the private pay insurers and Medicaid can pay for those. And the money that we had originally just been a straight out contract, which I know providers do want, but because it is easier, none of them want to mess with billing either. But if you don't have to have that direct contract that is just straight up with school education dollars going to a provider, that money can be left here. It's money you don't have to fight for the legislature for. You already have it, and you can do hire some tier 1 people with those monies that you were originally paying for providers. So just trying to think a little bit differently about how we're utilizing the services from different agencies and sources of payments. It's a great conversation starter, Erin.
If I can add too, I think this is a part where we're going to be depending on the relationships with all of you to map how different schools do this, to be able to learn from one another. Because I think, like, for me, I'm very visual, And so it's almost like I already start kind of mapping out the streams, right? So what do we do with this part, and how can we do this part? And because it's going to be everyone starting from different places with different resources and different skill sets, I think the more options that we can map, the easier it'll be to try to explain and kind of coordinate and communicate with other people on what those options look like. But we're going to need you all for that, because you really have the important pieces that will help us. I can show you where to go get money, but you're going to have to help me understand how that works within the school. And at what threshold does it work, and maybe what threshold it doesn't. I mean, there might be just a basic number of this. Unless you have this many students, you should outsource, like what Superintendent Baszler was just talking about. Unless there's this many students, it's not going to be worth your administration. Run that through that, third party that's going to bill it for you. I mean, we may get to that kind of understanding. We're not there yet.
So can I ask a question? I see Allison Zyma is on from SEEK, and they do billing for Medicaid. How is this different than what SEEK is already doing? Because I know SEEK works with our local Lake Region Special Education to do some Medicaid billing for them. Allison?
Hey, everybody. So where we play that role is we kind of work as the middleman between the two, between the special ed unit and North Dakota Medicaid. So we have a software that allows it to be simpler for the providers to bill, so it's not hand entries and one-by-one data entry. But we've also done, some of the behind the scenes work of, with Kyle as our executive director, and where that came from with those Medicaid dollars and how they can be put back, where physician sign-off change, that was part of it. So it's some of that work. And there is a lot of talk within the consortium group of what it's going to look like if we have other entities outside coming in and trying to figure out how to best work within what our staff is and how we can use the private organizations outside of it. And it's just messy, kind of how Pam said I just wrote that down of how we can work with them and through the consortium, starting with that group, to maybe have them outline what it looks like in their school system, so we can try and figure some of that out, because we have some staff dedicated to do some of that work. And the conversations have started with some of those special ed directors. But everyone works so differently especially those multi-district units. Some things stay at the unit level, some get put back to each district. We don't really get the intel. We are a partner in it, but we don't dig into, we're not asking them how they're running their program, their funding, they're spending the dollars and allocating them how they see fit. We don't get into their business on that side of it all, but it is a place where maybe looking at it overarching to see what looks different in large school, single unit, small district, there's lots of differences. So I wrote that down as a place where, as a consortium, we can maybe start digging into some of that, of how it looks and where we can close some gaps or find some new options to make it work.
This is Pam. I think that's great. And one of the things that I would like to do is, and my goal after these meetings are done, was actually to reach out and see if we could have a meeting where I can also bring Medicaid to the table. Because a lot of the calls and questions I still get from schools are antiquated Medicaid decisions, not current ones. And I think it's difficult for everyone, there really is a difference between the chain of the channels of communication between the education system and the behavioral health system. We do everything that we think we can do to make public notice of our behavioral health stuff. And I still hear from schools like, well, we had no idea. And, vice versa, right? So I think that if we could actually work together and bring Medicaid in, I think a lot of things that used to be aren't still. And so I still do hear a lot of things that are like, yeah, but we can't bill this. And it's like, well, actually you can now. That changed a year ago. But again, it's hard to stay current. It's so big, right? Medicaid is huge. And it's hard, even as a DHS person, as a sister division, to stay current in all of those things. So I think if we could set up a meeting like that and just start kind of working through tools that would be helpful for schools to figure out where they fit, I would really appreciate that. So thank you.
Yeah, and I think we hear a lot of it too from our consortium admins and directors of, they don't know who can bill for some of those services, or we're not employing the right qualifications. And so that's where a lot of the confusion happens. And I know this was brought up on some of the other meetings too, of that's a place of work that we're trying to outline a little bit more to help the schools understand who, if they're going to employ someone, this is the best option to get the best bang for your buck on what all they can provide and what's billable, and then making sure those people are aligned with the right students that are those Medicaid eligible students. So there's a lot that has to go down the chain, but it's in the talks and we're trying.
Yeah, I think that's absolutely right. And one thing too, I didn't mention this earlier, I forgot, but most of the services in the 1915I are not master's level clinicians. So I often get asked like, okay, but we already know we have a behavioral health workforce issue. It's like, yep, I understand that. But you don't need a master's therapist to do respite or to do transportation or to do, in-home school or in-school supports for supported education. So almost all of the services, I mean, we even have family peer support. So you can have a family who has a child with a disability be paid to do peer support for another family who's navigated that same situation. That's a billable service within the 1915I. So if you think about it, it's not the same cast of characters as what we're used to seeing in behavioral health billing. It is expanding those support services around the child and family, not just the clinical, here's our 1 hour of therapy. So I think that's another thing, like people get concerned and go like, yeah, well, that won't work here because we don't have extra therapists. You don't need extra therapists. You have one therapist who directs care, and then you have all of those other people providing those services. No different than how you do in education, right? You have people that direct care, but how many aides and paraprofessionals are actually supporting that child hour by hour?
How do we get that kind of information out to the REAs in the schools more? Like that little tidbit right there is a big deal. And I feel like maybe we don't have all of the information at our fingertips. And maybe I'm speaking for myself, maybe I'm speaking for all of our superintendents and principals and personnel involved in these issues. So how do we get more of that? Here's what it is, here's what it's not, here's what it can be, here's how you could be using your dollars smarter.
So
that was
that
kind
to
of the
me,
intent. That was kind of the intent and purpose of this. Some picked up on it, others did not. And so we're still trying to get there. So we're hoping to get build that momentum of knowledge. So Pam, go ahead.
Yeah, I was just going to say, so, I mentioned the timeline we're working on. We have absolutely heard feedback like, hey, when we meet with you and we talk to you, like we get it. But then we all go back to our world and we don't get it. And we don't have anything to like reference. So the Medicaid 1915I just got done and submitted like a week and a half ago, like maybe 10 days. And here's the biggest issue. When that goes out for public comment, it's 118 pages. And most people don't necessarily even know how to decipher that. So now that I have a final version of what was submitted to CMS, we do want to be able to share that in pieces now, right? So like knowing the audience, who needs, like here's the 4 pages that have to do with supported education. That's important for you. You probably don't care about the housing stuff as much. So let's focus on that first. So I would love to be able to even, work with whether it's Allison or the REAs or whoever to say, we can put content together, shoot it by some people who work in education and can tell us, is this hitting the mark or not, before we even just do a mass distribution. And obviously we work with Superintendent Baszler and everybody else, but it's just great to get eyes on products to say, does this ring true for you? And I mean, would this make sense? Because it is the scenarios to me that are important. Like if you think about that with a family with a child, having another family provide that support, even if the school doesn't feel the benefit, I think the family would. And in the end, the student will benefit, right? But those scenarios have to be written out now. And then ultimately, we also have to communicate the feds can take those things out or change them. So we also have to be able to communicate, this is what is proposed. We think most of it will stay, but we can't promise before we get federal approval. So that's the one sticky part, right? Is just that having people be able to understand that we think 95% of it is solid and won't change, but we can't guarantee that.
Yeah, if there's ways we can get that communication where it's, the quick and dirty facts, it's those scenarios, it's a small school example, large school example. I don't know if any of these kinds of things could be incorporated into the DPI weekly blasts. because that's where administrators are trained to look now for the must-have information about how to use their dollars and things like that. But I think we're missing some opportunities. I know we're missing some opportunities, and I know that they're looking for more efficiencies and better coordination of services. So
here's where we're at too. And Pam's been working remotely. We're all in COVID. So prior to all of this, Pam was looking to hire someone that was specifically kind of walked both worlds, if you will, one in behavioral health and one in education, to help her with the deployment of all of this, the implementation. We recognize, so Robin Lang was our former Safe and Healthy program coordinator. She was absolutely 100% a counselor, school counselor, but not necessarily an administrator with those types of, so we are in the process of advertising as well. We need to have someone like with a broad capacity that is going to be able to connect with Pam's walk to world person, and we have somebody that has a walk to worlds type of background, because we do then need to get out to the to our administrators via that constant contact blast. And so if you know anybody like that would love to work, and we're all into telecommuting now, we'd love to have you shoot their names our way, because we're both looking for a person like that, because that is, I think, the missing link right now. It took us an hour to get to some substantive types of conversation, because we still were trying to figure out vernacular with each other and what we were trying to say and what we needed. And so we need Pam's person and DPI's person to develop that relationship, so it can be more frequent in those constant contact blasts.
Yeah, we are still planning to post that position. So we will have a full-time position that'll be specifically running some of the highlighted things from Senate Bill 2012 that we talked about. So the behavioral health resource coordinators, the pilots, both the pilots at Simley and that's expanding, plus the behavioral health grant. I mean, we have enough work just on the behavioral health side to have one person who's well-versed and absolutely experienced in this. And then, is connected to both worlds by, so we're looking for someone with education experience. We can teach even behavioral health. You know what I mean? Like, I'm not necessarily looking for, because I have an entire team of 40 people that can do behavioral health all day long. The crosswalk for us is the important part. So yeah, that's what we're looking for. And we do plan to post that position shortly. Again, it was delayed 8 weeks. We had this already kind of set to go out before COVID, but we're still hoping to get good qualified candidates and that people will be interested.
And we too are looking for that replacement as well. And previously, that Safe and Healthy coordinator was doing a lot of things that were suspension, expulsion. How many gun-related expulsions were there? How many, threat expulsion? That's not what we need anymore. We can do reports and we can collect information. We need somebody that is an educator, but also has some behavioral health background. So again, Pam, you and I haven't talked about this, but similarly, how we have the Head Start person paid for by DHS in our office area with DPI, I think it might be a good idea for us to even, wherever they are, wherever their space, to have those two people together, because I think they'll be similarly working on these, and exactly what our legislators want us to do, two different agencies working together. So we'll talk more.
Yes, thank you all for this discussion, though. Like, taking notes myself. And sorry for not being on camera. If I have my camera on, then I lose my connectivity. So I've only been able to do the screen share for right now. But I've been taking notes too. This has actually been a really helpful conversation for me to just kind of keep pushing forward on these next steps, because it was a really big lift to get all of the things passed through administrative rules and get the plans written and all of that. But now we're really on to the phase of communication and kind of learning more about the hows and the whats now. So thank you for the discussion. It was very helpful for me.
I would echo that. Thank you. As always, you guys are rocking it. Thank you.
Jean, do you have
Thanks
anything to add? I see you've been on for a little bit here.
Are you talking to me?
Yeah, it seemed like you were maybe waiting to jump in. Is there anything you wanted to add? Jean's one of our counselors in the region.
I've had a lot of stuff going through my head, and I know when you're talking about hiring a person to come into the school system, I have heard of a number of different methods of making that work. Down by Fargo, they're getting like NDSU interns in to do that work, and they don't have to necessarily, I mean, they are billed out, but not nearly as much as a full certified counselor would have to, but they're getting the interns that are going into mental health, not necessarily the school mental health, but the other community side. Up here in Devil's Lake, it's a little tougher to get those people. I even mentioned it one time and they just kind of like laughed and said, no, we're not driving up there, sorry. But I know what the middle school in Devil's Lake does have a counselor and independent counselor come in to the school 1 day a week. And I believe they bill out to their insurance, but then they get up to the high school and we don't have that option for them. We haven't coordinated that. I had not even heard of it until one of the kids had mentioned it to me and I'm like, what? So I think there's a lot of conversation that needs to happen, even within our school districts, to find out what is going on in our schools and like what's working for one and transitioning it into the next level. I know we had an MTSS meeting this morning and there's a lot of things we're working on too to get all of the pieces together and try and smooth out some of the things that we're doing good things, but it's not all working together necessarily. So yeah, that's about as sorry to just kind of brainstorm here, but that's kind of what's been going through my thoughts.
Good stuff. Thanks, Jane. Nice to see you. All right, thank you very much. Thanks to the REA. Allie, thanks for helping us coordinate all of these. And Allie, say hi to your dad for me if you can. So Allie's dad was my high school accounting teacher. So if I get numbers wrong as you report out, it's his fault, not mine. But yeah, good to see you again.
Yeah, I'll tell him hi.
Good, very good. Take care. We'll see you all later. Be safe.
Thanks, everybody.
Thank you.
Thank you all for being on. Take care.
Thank you. Appreciate it.